Guys, let's start with vascular surgery today. Vascular surgery is very important. But from every year, vascular surgery, they give questions. Two, three, four, five, six, sometimes two questions, sometimes three, sometimes four. Okay, like these. So only thing that is guaranteed from paper two is emergency trauma perioperative. Why do I say it in every class? Because humans are forgetful. You, we all are forgetful. So we forget. Whenever we start studying these things, we start studying pediatric surgery, vascular surgery, we love it so much. We love it so much. We keep studying, but no, that will not help. That will not help. So you study more emergency trauma perioperative. Every moment you find every moment you find yourself sitting, whenever you are sitting in your ward or at your car or at your private car or toilet, watch our flashcards and arrows. Flashcards, arrows. Watch our flashcards and arrows. Now, aneurysm types, true, false, they will not ask you questions like it. Okay, just remember one thing, that compression ultrasound, what to do in case of a false aneurysm. If you have studied previously, that's enough. Now you just know what to do. What's the treatment of a false aneurysm? That's what you do. Okay, then management of aortic aneurysm according to size. We have a short video about aneurysm, and this is a very beautiful video. I will share the link. Watch it from YouTube if you want. It's just some basic stuff, not important for your exam. But if you want to recap, then you can. But you will have questions from here. You will have questions from here, and don't bother about these two. They will not give you questions from these two. These two you will not have question. Even if you have, you don't bother about 6 months or 3 months or 5 months. You will see only they give you one option. They will not give you two options, one containing USG every 6 months, one containing USG every 3 months. No, only one option like USG, and the other options are like surgery immediately, all these options. Okay, study this box, 100% important. Then forget it. Then hold on guys, I'm with you. Okay, reading. Reading, these things are reading, they don't give much question from it, but this question this question is important. This is a question directly from recent exams. Then classification, this one, type A, type B, Stanford classification. This one, DBACI, they don't give it. Still, if you have studied earlier, you can just study this. You can just give a reading. But this one, most important. This one is most important. Workup, you just have to know the serial. You just have to know the serial. This will help you to take decisions. So this is 100% important for your next upcoming exam. Then not important. Only thing that is important is an entrapment limb. Okay, entrapment limb. They don't give questions. They don't give much questions from here. From these two, embolus and thrombus. What to do when there's an embolus? What to do? There's a thrombus. Okay, I have explained previously about uh, embolus. Just remember this one. They will give you pulmonary embolism scenario. What's the scenario they will give? They will give you a person having long bone fracture, and after one day or the next day he is having shortness of breath. So what is it? Write me in the comment box. What is it? Now, they will give you the same question, and they will tell you that after 7 to 10 days, he is having shortness of breath. What is it? All of you know this is pulmonary embolism. And what is this one? You have to tell me, write it in the chat box. Now, this person will have shortness of breath and you will not have time. Most of the time you will have death. You will have death in your scenario. That's pulmonary embolism. Okay, in this case. But if they say what to do now, remember CTPA and embolectomy is your option. Embolectomy with what? Don't worry about it. CTP and embolectomy will be in just one option. Whatever they add, alteplase or whatever, they will add with it. And you will have no other option containing CTPA and embolectomy. Listen very carefully what I say. You will have the same thing in your exam. So then what are the other options? Sudden shortness of breath. Sudden shortness of breath in a pregnant woman. What is it? Or after a long flight, sudden shortness of breath in a pregnant woman or a long flight, it's always shortness of breath. Always pulmonary embolism. Now, what do you do in these cases? What do you do? If the patient is stable, give low molecular weight heparin. If the patient is, if the patient fainted, unstable, do CTPA and embolectomy. You will understand from the scenario. You are not that dumb. You will understand. You will understand. So these scenarios you must be very clear about. Then, sorry guys. Then, complications of an entrapped limb. Complications of an entrapped limb. You will, it is a must have question because this is an emergency question. This is not vascular surgery question, but due to blood vessel occlusion or after compartment syndrome, if you reperfuse the area, that can get again like a place is tightly bandaged or ischemic for some time, and you give perfusion in that area to make it easy. So that area, immediately a lot of blood can enter that area and increase the compartment pressure very much, and that may lead to compartment syndrome. That happens in abdominal aortic aneurysm, OT. They will give you scenario containing abdominal aortic aneurysm. Remember the scenario. Remember what I say. These will come your exam with exact words. That abdominal aortic aneurysm. Then that person got operated and then he is having abdominal pain now. What do you do now? First thing to do, you do compartment pressure measurement. Measure the compartment pressure. Now, in case of leg, why don't we talk about compartment pressure? Because in leg, that's a clinical diagnosis. You can do compartment pressure, but that will not help you much. That will waste your time. It's a clinical diagnosis. From history, you know, and you are very sure, because inside leg we don't have a kidney, inside leg we don't have bowel, right? We don't have a liver inside leg, but those we have in abdomen, which can cause pain too. So that's why we need to check the compartment pressure in abdomen, because we have to know what's the reason. There may be other differentials, but in leg we don't have any other differentials than that. If someone has pain, severe pain after casting, severe pain, that's only compartment syndrome. You do 4 compartment decompression. So these two questions have two different answers. These are the reasons. So you have to be very careful a bit, very careful about it. So this, just give a reading, not so important, but this one is 100% important. For what? 100%. I will say 200% important. Why 200%? Because you will have questions from here in part A and part B too. See, guys, I haven't given part B yet. I didn't sit for it. I don't take classes for part B, but I know some things, that some topics are important for both part A and both part B. I just mentioned that. So I just mentioned that. So this is 200% important. You will have questions from here. What kind of questions? I will tell you every single question that will come from this. They will tell you that a person, you will get two kind of scenarios. Number one, a person got a person drank too much alcohol and passed out. We all know that guy in our friend who says, I can drink, though Muslims we don't drink, but there are some people who drinks. Okay, so we are not gonna judge people. So we all have that friend who says, I don't, I have no problem. I can drink a lot. I can drink a lot. I can drink a lot. And they drink and they make your life very miserable. And they sleep wherever they can. So you will have a patient who has had too much alcohol and he slept on his left or right hand for 7 hours straight. And now his hand is pale and cold. That's one scenario. Similar scenario. That's why I'm giving it in just one heading. Second scenario, you will have that a person got trapped under Rana Plaza. Person got trapped under Rana Plaza. That means a person got trapped under a beam or something for 2, 3, or 6 hours. Now his hand is cold and pale. So, do we have any other organ inside hand? Any other DD for that? No, only one and only DD. That is that in case of that, what will happen? That's an entrapped limb. Very easy diagnosis. They will not ask you diagnosis. That's an entrapped limb. What will happen? That person will have skeletal muscle destruction. Skeletal muscle destruction. I have described all these things in classes, so I'm not going to tell you more details. But I'm just saying that that person will have skeletal muscle destruction, and skeletal muscle have from there, from destructed skeletal muscle we will have so rhabdomyolysis. Lysis is destruction. We all know rhabdomyolysis, skeletal muscle destruction. We will have myoglobin released from those area. These myoglobin will make urine dark in color, but that person previously didn't have hematuria, right? That person is having dark urine right now after entrapment. So that red urine is not due to blood. That's just myoglobin that's passing through our glomerulus, and this is thick and heavy. This will block this area. Myoglobin will block this area. Your proximal convoluted tubule will get blocked and your kidney will get injured immediately. You will have AKI. Sorry guys, that means AKI. So what happens? Your entrapped limb got entrapped. It released myoglobin. This myoglobin will go to kidney. That will be excreted through kidney, and our proximal convoluted tubule will get blocked. So what do? Anytime we see this, we will do number one. We will give saline, a lot of saline, a lot of saline. How much saline? We don't know how much. As many saline, as much saline as it needs for 100 to 200, and some sources say 300 ml per hour urine output. We will give so much saline that we get 300 to 200 or 300 ml urine per hour output until the urine becomes white again. Urine becomes white again. Okay, so this is the management of it. This is the management. And tissues are bags of potassium. A lot of potassium are inside your tissue. So we can have a hyperkalemia too. If they say that person is having hyperkalemia, they will always give you a number more than 6. Always in these cases, because they want to know that what's the management after that. You have to dialyze the patient. You do dialysis. Okay, you do dialysis. So this is the serial that And this is called rhabdomyolysis. What's the color? This color. You will have the color I used here for this color urine. You will have it. That's why we colored it like this. This is called color coding. So your brain subconsciously remembers the color of rhabdomyolysis. We have put so much effort into our book. We know that's why our candidates results so good. Candidates results are so good because everything is precise and thoughtful. So this one, renal replacement therapy, we use dialysis for that. So this is your 200% important chart. You can have two questions only from this chart. Only one urine output question and one question, what is it? This is rhabdomyolysis. Two questions from here only. Chronic limb ischemia, you don't need that, forget it. And you can have a question from claudication. This is very common, so 100% important. This will be now. You get worried about it. You get very much worried about it. So don't get worried. We have a short video about it, that claudication and what are the managements. I will give you that short video link. If you have forgotten, you can watch it. See, let me tell you what they are going to do. So this is our common iliac artery. Common iliac artery. This is our external iliac artery. This is our internal iliac artery. EIA. EIA. From EIA, we have superficial femoral artery. Let's just show in one side. Okay, we need that. Okay. SFA, then we have popliteal artery. And from popliteal, we have, just remember this, from popliteal, we have anterior tibial, posterior tibial, lateral, just anterior tibial. I'm just showing anterior tibial and posterior tibial, these two, because only these they give. Popliteal artery, I'm just writing pop. So this is pop, this is anterior tibial. Anterior tibial, this is popliteal. So where is the block? Most of the time you get question that popliteal artery will start from when the adductor canal end starts. Adductor canal starts. Okay, just like the class. Now, if you have a block right here, so it's inside popliteal muscle. Okay, so you will have pain only in lower and only in lower part of popliteal muscle, popliteal and leg muscles. Okay, so in case of popliteal artery occlusion, you will have pain. Just remember the things I say. Others, forget it. Because exam is near, you don't need to cloud your mind with unnecessary things. Popliteal, and what do you do? I'm telling you later on what do you do. So popliteal, you will have pain in lower half of popliteal muscle. Only lower half, not upper half. You will not have pain in upper half. Plus leg. Plus, of course, up to foot. Very simple. But you have SFA occlusion, you will have total popliteal muscle. Total popliteal muscle pain plus leg, all compartments and foot. Now, what's the difference? So this is the difference. If they only say that popliteal muscle pain, that means total popliteal muscle is participating in the pain. Okay. But if they say that only lower portion of popliteal muscle, only in that case you choose popliteal artery. Otherwise you choose SFA because it's above, and if total popliteal muscle is causing the pain, then SFA is occluded. Most commonly at this place, adductor canal, most commonly. Okay, and others you know. Others you know. If external iliac artery occluded, where will you have pain? Lower than that, thigh. Thigh will be having total thigh, total thigh, total thigh from top to bottom. And of course, you can have this. Sometimes they don't mention it. Sometimes they don't mention it. But if you have SFA occlusion at upper part, what will happen? You can have pain in lower thigh plus popliteal and others. So same thing. If they mention entire thigh or only thigh, so that means the occlusion is in external iliac artery. If they say lower thigh, that means occlusion is lower down external iliac artery, most probably SFA upper part. Okay, then don't ask me questions again about these imaginary questions. Don't, because you will be wasting your time and you will be wasting my time too. Only these things, study only these things. Other things you don't need that. Then again, if CIA is occluded, what will happen? If common iliac artery is occluded, you will have pain, both external iliac artery distribution and internal iliac artery distribution. Now, most commonly, what do we have? From a internal iliac artery, we have gluteal vessels, anterior gluteal vessels and no, sorry, superior gluteal vessels and inferior gluteal vessels, right? We have both gluteal vessels. So pain in buttock is a characteristic feature of internal iliac artery occlusion. So if there's only pain in buttock mentioned, no other pain mentioned, so your first choice would be internal iliac artery. If they mention pain in buttock plus pain in thigh, so of course IIA, EIA both are affected. So common iliac artery is occluded. Simple as that. Simple and easy. I have told you in class all these things, but these things are a little bit tough. You people keep forgetting because we are human. This is very easy. We will be forgetting. Don't worry about it. So I'm summarizing it. Number one, if pain in buttock only, then internal iliac artery. Now, think one thing. They say they pain in buttock only, but they didn't give internal iliac artery in options. What do you have to do? You have to choose the best one. So, if the occlusion is in internal iliac artery or occlusion is in CIA, both can cause buttock pain because these are both occluding superior gluteal and inferior gluteal. But with it, additionally, we can have EIA. But we have buttock pain, but we don't have internal iliac artery in option. We go for the best one. The best one would be CIA. So second option, CIA. Second best. Number two, buttock only or buttock plus thigh. So of course, we are very sure this is common iliac artery. Number three, thigh, only thigh mentioned. That means total thigh. So we external iliac artery. Same goes for that. If we don't have external iliac artery in option, second best would be common iliac artery. Simple and easy. Guys, you will feel, just even if it doesn't come to your exam, you will feel so confident and so good during exam day. You will feel like nothing is missed. You know everything. And that's the secret of our success, guys. Just follow what I say. Number four, if they say lower thigh, you already know that occlusion is in SFA. Now remember one thing, that if they say lower thigh plus lower buttock, that's a tricky question, guys. What do we know? We know that femoral artery gives two branches: superficial femoral artery, arteria profunda femoris. Arteria profunda femoris will give two arteries, medial circumflex femoral and lateral circumflex femoral artery, which supplies deep to our hip joint, and those can cause lower buttock pain. So that's when we choose our femoral artery only. So femoral artery or arteria profunda femoris, if they give you specifically. Number five, popliteal muscle pain or pain in calf muscle. Of course, SFA most commonly in adductor canal. Number six, lower popliteal muscle. Of course, popliteal artery. Number 7 and the last one. Pain in leg, foot. They told you. So it's popliteal artery for sure. If popliteal is not an option, one step above superficial femoral artery will be the option. Others tibial they don't give, but if you know all these things, you can answer. If they by chance give that, you will be able to answer that. This is a very important thing, that buttock pain plus erectile dysfunction. Buttock pain plus erectile dysfunction. Why? Because all pelvic organs and dorsal artery of penis comes from your from the root is common iliac artery, we all know. So CIA is the best option. Then internal iliac artery is the second best option. This is the best option in case of that. They don't ask, but they just ask that Leriche syndrome. What is Leriche syndrome? Vascular neurogenic claudication reading right now not important. Workup not important. ABPI important, not that much. They will just ask you that which ABPI is good. Just remember it. Okay, this is I will say 80% important. 80% important. Then arterial grafts. They don't ask you much question from it. You will have only one or two questions, and we have a video about bypass. We have a video about bypass. We will give you that. We will give you that because they will give you just one question from here. Every year they give one question. You all know this is very easy. Only 6 type of question you get from bypass. Number 1. This is our CIA. This is our EIA. EIA. Number 1 option. EIA blocked only or femoral blocked only. Only one-sided, one block. One block, long length. So what is the bypass you are going to do? Femoro-femoral crossover. Femoro-femoral crossover. Now, you might ask, is it anatomical or extra anatomical? Not important, guys. Not important. Don't just bother about these things. This is extra anatomical. We all know because blood doesn't go from one femur to another femur. I know you guys, you people ask these questions. That's why I'm clearing you it beforehand. That I have seen a lot of students in just 1 or 2 years. I have like around 300 to 400 people got into my course. A lot of people didn't give the exam because of a lot of reasons. Every year this happens, but I know people what kind of questions people. This is not important, not important at all. Chill, bro. This is not important. So don't waste your time. Use your time to sleep. Have fun. So it is femoral crossover. If one-sided block only, long segment, because in long segment we cannot do angioplasty. This is not possible. Angioplasty. So then second question, they will tell you that both sided CIA or EIA, both sided block, both sided. Okay, both sided block. What will you do? You cannot pass blood from here to here, right? Both sided, what kind of block? CIA block. Or they can say both sided external iliac artery block. Can we do femoro-femoral crossover? No, we can't. Okay. So what do we do now? Then we do aortofemoral. Okay. Or one thing I missed. CIA at the starting point, occluded. So what do you do? Two sides are blocked. Two sides blocked. So we cannot take blood from here. So we have to take from above. So what do? We do aortofemoral. Aortofemoral bypass. Aortofemoral. So one-sided aorta we take from here. Then we take from here. Okay. So we can do it in two ways. See, directly like this. So we get blood directly. Now normally blood from aorta goes to femur. So this is anatomic bypass. Anatomic. Now if they mention that person have IHD history or arrhythmia or heart is weak due to any reason, anything mentioned about heart, remember you cannot take from aorta, you have to take from axillary artery. So we will do axillofemoral bypass. Most of the time they give you this question, most of the time. So you will have only these 2 3 types of questions from here. Just remember these two. And of course palliation question, the questions you have seen in our mocks, that kind of question, long segment. They will mention long segment, SFA occluded, then popliteal artery occluded, then posterior tibial artery occluded, 3 arteries occluded, or external iliac artery occluded, SFA occluded. That means long segment occluded. So that we cannot correct most of the time. So what will we do? We cannot do femoral crossover, right? Because femoral is occluded. We cannot do axillofemoral. We cannot do femorofemoral. What do we do then? Palliate. Palliate. So you will have just these 3 types of scenarios. I have mentioned some other types of scenarios, but those are not important for exam now. Amputation right now not important. They will not ask. Then just remember in British strokes we patella preserved. Patella preserved. Okay. And remember 2 lateral flaps we take in skew flap. Just remember this. And amputation of the midfoot. No, not this one. Amputation pro ankle is called Symes amputation. Just the name. Just to see, not important. Madura foot not important for your exam now. Trash foot. Yes, you can have a reading, not so important. Then arteries, just remember Takayasu arteritis. Not so important. Others just give a reading. Not so important. Not so important. Venous disease, this one. Long flight, just give a reading. Just give a reading. You know what to do. SOP, stable, low molecular weight heparin, this one. Then saphenopharyngis, give a reading. Not so important these days. They don't ask. Other vascular disease, this one is important. Adductor canal syndrome, subclavian steal syndrome, Raynaud's phenomenon. All 4 are important. So this is 100% important. Study these 4. I have told you previously, don't worry about it. This will be enough. Now, pyelonephritis, that's a medical disease. They don't generally give, but give a reading. You will understand if it comes. But this is 100% important. Don't worry about radio opaque, radio dense. Same thing. Same thing. Don't go for radiological appearance. Don't. I've told you several times. You have other clues. Go for other clues. If nothing mentioned, choose the most common stone, oxalate stone. They just say person is having pain in the flank from loin to groin. Now he has stone. What kind of stone it is? Calcium oxalate. Forget about radiopaque, radiolucent. Forget it. Cystine stone. You will have this. Radiopaque, radiodense, same thing. Radiolucent, we all know. Sometimes we can't see the stone at all. So why radiolucency? Because this is important, but for part A, it's not important. I'm just saying this. I'm not saying this is not important at all. It will be important in your future. But right now, you can have the stone according to tips of transverse processes of L1 vertebra. So that vertebra is already white. The stone is also white. How would you differentiate there's a stone if it's radio opaque or radiolucent? You cannot. So you cannot rely on that with X-ray. So cystine stone. What are the clues? Memorize this. His dad had similar pain. They will mention a family history. Cystine stone. Simple. And ground glass. Forget it, guys. You will not get it in your exam. But for knowing it's important. Uric acid stone, they will tell you about chemotherapy, radiotherapy, gout. Simple. Chemotherapy, radiotherapy, gout with flank pain, uric acid stone. Then of course, calcium phosphate stone. This is most dense, almost bone-like opacity. So it's almost bone-like. So can you differentiate if it's over transverse process of lumbar vertebra? No, you can't. So forget it. They sometimes mention renal tubular acidosis. Okay. So if you know other clues, you can always know that if they have given a calcium phosphate stone question. Then struvite stone, 3 questions. Number 1, they will tell you staghorn stone. This is radiolucent. You cannot see in uric acid stone also radiolucent. Largest stone, remember which caused by recurrent infection. Very important. Recurrent infection. Infection by Proteus mirabilis. Nothing else. Nothing else. Then staghorn stone, they will tell you recurrent infection with Proteus and what kind of stone you are going to get, staghorn stone or struvite stone. Give a reading. So if you don't see, most of the time you will not be able to see in X-ray. That's very possible. So you order a non-contrast CT. Treatment 100% important. Remember, any obstruction or infection, any obstruction, or they say the person has hydronephrosis, first thing to do is to stent or urgent decompression or ureterostomy. They always give stent. Okay, don't worry about it. Always give stent. Rupture of the urethra, 100% important. You will get questions from here. From emergency. Emergency. Remember these three. Remember these three. 100% important. Very important. Ascending or retrograde urethrogram in case of rupture urethra. Bladder rupture. For bladder rupture, we do IVU and cystourethrogram. But sometimes people give exams. After exam, they cannot remember what came. So if they give retrograde urethrogram, you can, but there is no IVU cystourethrogram. You can do retrograde, not a problem. Do retrograde. And in case they mention hydronephrosis, you do enterograde or antigrade, maybe antigrade urethrogram. They just ask the name of the investigation. Simple. Testicular disease, 100% important. Which one is important? Torsion of testis. How? I have told you. Epididymoarthritis, give a reading, not so important. And torsion of testicular hydatid of Morgagni, the ones I told you in class and question discussion. Just remember those part. Swelling of the scrotum, hydrocele. This is important. Hematocele, not so important, but give a reading. Varicocele, they will just ask you, where does it happen? Left testicular vein. Anatomical question, where does left testicular vein drain? In left renal vein. They give you this question. Spermatocele and hernia question are from anatomy. They will not give you this kind of questions here. Remember this point. Very important. Then other testicular conditions, give a reading. Retractile testis, undescended testis. Okay. And this one from embryology. This one from embryology. Just this statement. Testicular tumors, 100% important. Seminoma important, teratoma important, yolk sac, embryonal carcinoma. These are important. Choriocarcinoma, 50% important. Spermatocytic tumor, not important. Mixed tumor, not important. Okay. Priya Prism 100% important. They give you this question. They give you this question, this one mainly. But give a study it. But study it before exam. What to give if it doesn't settle? Epinephrine, phenylephrine. Okay, phenylephrine. BPH, prosthetic carcinoma. Give a reading. Not so important. No questions come. TARP syndrome 100% important. Question comes from emergency. Gleason score 100% important. They give you questions from here. They give a lot of questions from urology. Gleason's pattern, you know already, not important right now. Now, mass in kidney, adult polycystic kidney disease, give a reading. Others, not important. Then, nephroblastoma, neuroblastoma, this one 100% important. This one, give a reading, not so important. Renal imaging, DMSA, MAG3, non-contrast CT, hydronephrosis, urethra rupture, bladder rupture. Just these things. Okay, just these things. CKD. Okay, CKD. We do DMSA. Carcinoma, 100% important. They give you separate questions for it. Staging, not important. Not important. You can give a reading if you want, but not important. Remember, most common type is clear cell. Most common. Most common is clear cell. That's it. Treatment of RCC. Guys, see. Just this one. Just these two. Just remember these two. Okay, just remember these two. And just name. These are just name. What do they do? Tyrosine kinase inhibitor. Then a PD-1 inhibitor. All these things. Just name. What do they do? We have it in our arrows. But still, not so important. I will say 50% important. But this is important. Sometimes they give questions. But don't worry if you can't even answer those. Those will be around 10 to 20% questions which no one can answer. So don't worry about it. Then bladder and urethra cancer, you can give a reading. You can give a reading. I have given everything here noted. So you will have the same questions with the same words. Don't panic. Just keep your head cool and answer. ADPKD, give a reading. They can sometimes they give you these four things and just say what is it. So it's a very easy thing. This one not important. They will not ask you this question. But remember, what are the other things he can have? Other things, these things. Okay, these things they can have with ADPKD. Horseshoe kidney, you all know what to study. Where does it stop? At the level of IMA. Where does it stop? It descends from below upwards. Kidney descends from pelvis to abdomen. Ascends. Sorry, guys. And it stops ascending at IMA origin, that is lumbar 3. Remember this point, very important. This one, this line. Most commonly used in lower part. Most common associated carcinoma with it RCC. 100% important with these questions. This one not so important. Patients asymptomatic. Not so important. Renal agency is not so important right now. No. This one, just study this line. Yellow mask. If you have question, you will have directly this line. Directly, you will have this line. Yellow mask found during hernioplasty. Then pediatric surgery. This is 100% important, guys. 100% important. 100%. You can have question from duodenal atresia, pyloric stenosis. You can have question from malrotational volvulus. Then you will must have question from Hirschsprung's, meconium ileus. Most commonly these two, because that's why these are red. Then esophageal atresia, no. Then biliary atresia, no. They don't give. Still, okay. They, let's say it's 50%. 50%. Okay. Necrotizing enterocolitis, intussusception. Everything is important. You must remember. You must remember these things. I have written it down. These things I have written down. I have written down from previous questions. All the things they give in exam as presentation, I have mentioned it here. So you must remember these things. It sometimes it might not. That's why sometimes it might not uh, match with your reference books. Why? Because I have given clinical scenarios from exam. I have given here from clinical scenarios of exam. So that's why if they give you these distorted scenarios, you don't get confused. That's why. Okay, so remember, see Hirschsprung's disease. Hirschsprung's disease and meconium illness. You will have this question that about 24 hours have passed, a person does not have passed meconium yet. Meconium. Meconium yet. They will say yet. If they say 24 hour, that still your first diagnosis would be meconium ileus. Meconium ileus. But Hirschsprung's will be your first DD, right? If 48 hours have passed and that person did not pass any meconium, so then it becomes Hirschsprung's becomes the first one. Hirschsprung's becomes the first one after 48 hours. Before 48 hours, anytime if they say they did not pass meconium yet, your first provisional diagnosis is meconium ileus. First provisional diagnosis is meconium ileus. They ask you this tricky question. So you will have questions from here. All these things. Acute appendicitis, mesenteric adenitis, they will not give you questions from here because these are not so common. Remember this vomiting chart, vomiting with fast feed, duodenal atresia, vomiting with abdominal distension, 3 to 7 days after birth, malnutrition with volvulus. I might have said in one of my recall session that vomiting with fast feed in pyloric stenosis. If you haven't seen it, it's okay. But if you have seen it, I have this correction. I have this correction, that is vomiting with fast feed will always be duodenal atresia. Always. 3 to 7 days after birth, malnutrition of volvulus. If you have no clue, only vomiting, from the timing of vomiting, you diagnosis, this is 100% important. Necrotizing enterocolitis, pyloric stenosis, 2 to 6 weeks after birth. Or after 2-3 days, still, 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 only vomiting, no abdominal distension, but only vomiting. No abdominal distension, only vomiting, 2-3 days, pyloric stenosis. 2-3 days vomiting plus abdominal distension, then malrotation with volvulus. Malrotation with volvulus. Then Vectral, this one, esophageal fistula, esophageal atresia. Remember, person will have all these things with discharge from mouth. So they are giving these questions recently. So these are very important. Just see it. Sometimes they give picture or they tell you that a sac outside through umbilicus. Not important, they don't give, just you can just see it. Meckel's diverticulum, remember this line. Remember this line and this line. Patent vital intestinal duct, artery supply, and these three lines. Sorry guys, these three lines. They give you these three lines. One by 1 year this question, 1 year this question, 1 year this question. Not together, but year by year they change it. Rotate these three questions. Umbilical hernia. Remember umbilical hernia? You can have question from umbilical hernia. This is 100% important. Recently, they are giving questions from hernia a lot. Remember, umbilical hernia can resolve in 1 to 3 years. Okay, but if the child is 3 years and he has umbilical hernia, you will tell him to wait up to 5 years. And even after 5 years, it's more than 1.5 centimeter, you operate it. Operate it. That's not important. Patent urachus, this is important, 100% important. I have told you previously, I will not tell you now because I don't have that much time. I will not waste your time too. Remember, osteitis, phimosis, paraphimosis. Of course, balanitis, most common orgasm. Sorry, not orgasm. Pardon my mistake. Organism. Sorry, guys. So this one not important. This one is important. Just the names. Just the name and these two lines. These two lines. Some frequently asked questions. These are your embryology. All the questions of embryology are here. Or most of them. All of them are here. And others we have it in. So you don't have nothing else from embryology. Nothing else from embryology. Nothing else. Just remember these things. These lines from embryology. Head neck surgery. Midline swelling. They will give you questions from thyroglossal cyst. Thyroid gland swelling, you will not have question like it. You will not have it. Simple thyroid cyst, they don't give. Lymphoma, they will tell you that a person is having enlarged cervical lymph nodes with CD20 positive. Anytime anything is CD20 positive, that's a lymphoma. No matter whatever the history is, a person can have Hashimoto. Then after a long time, he is CD20 positive. The Hashimoto has been progressed to lymphoma. What kind of lymphoma? Non-Hodgkin's B cell lymphoma. Why non-Hodgkin's? Because they just say CD20 positive. They didn't say owl eye appearance seen on histology. That means figure of 8, that is Reed-Sternberg cell. Reed-Sternberg cell. If they say this only in that case, that is Hodgkin's lymphoma. But from Hashimoto, we don't have Hodgkin's lymphoma. We have only non-Hodgkin's beta cell, B cell lymphoma. Sorry, guys. Branchial cyst, important. Carotid artery, important. Carotid body tumor, chemodictoma, important. Pharyngeal pouch, important. Cystic hygroma, important. Infantile hemangioma, not important. Ludwig's angina, important. How much? 50% important. Then just some picture. If you have studied previously, good. If you haven't, don't worry about it. Just study the box. Just study Ludwig's angina, 100% important. Salivary gland tumors, not so important. Give a reading. If you want to study, study only one. This one. Others, just you don't even have to look at it. Forget it. Malignant mucoepidermoid carcinoma. This one. This one, mucoepidermoid carcinoma. If you want to study, study only this one. This is not important. Forget it. They don't ask. Other disease, you can have this question at your exam. This picture, this picture, particularly this one. Just remember this one. What is it? This is ranula. And which gland is involved? Sublingual gland. Sublingual gland is involved. Okay, this is 100% important. These pictures are not important. Sjogren's syndrome, this one. Some 10 to 20% questions come from here. So this is 100% important. Atypical questions. Head injury, of course, 100% important. You will have anatomy questions and diagnosis questions from head injury, mostly from EDH, SDH, and SAH. These three. These two doesn't come in exam. Still, if you want, you can study. Can give a reading, not important. Glasgow Coma scale, you all know. We have a short video. Watch it. If you have forgotten it, you will have one question from here. From CT guideline, you will have within 1 hour, and child, you will not have mostly any question. So CT guideline within 1 hour and within 8 hours, you have to know. And what are the things you should be focus on? Most of the time they give number one. They give vomiting. Vomiting more than 2 times. You must remember this. Number two, loss of consciousness. But most of the time they don't give loss of consciousness. Loss of consciousness they don't give. But vomiting more than 2 times, remember it. If you see, and deep skull fracture, you people always make a mistake with it. I have told you. depressed skull fracture. If they ask you when to do CT, remember within 1 hour. But CT can take time. That person will have to list for CT, wait for CT, but depressed skull fracture is emergency. So immediately, what do? First thing you do, you refer to neurosurgery. Refer to neurosurgery, and then you do CT if you have that option. So this is the first option. Refer to neurosurgery within 5 minutes, CT within 1 hour. Now you know which one is more important, which one comes first. You know it. Now again, they will give you questions like within 8 hours. What are the question? They will give you a patient more than 65-year-old, and they will tell you that person is taking apixaban. So what do? You do CT within 8 hours. Okay, or warfarin. Warfarin. Simple. Now stroke, you all know this question. This is 100% important, and just this is 100% important. You study it. I have told you previously all these things. Raised ICP, you know it. Cushing triad. What is the Cushing triad, and what is the non? Guys, give me 1 minute. I'm coming back. My kids are screaming, so I'm just coming back within 5 minutes. নাইস, গ্রেট। অ্যান্ড অর্ক এবং এমডি ওয়াসিউর রহমান, আমি আসলে আপনাদেরকে নিয়ে খুবই আশাবাদী। অ্যাকচুয়ালি আমি সবাইকে নিয়েই আশাবাদী, ইউ নো, আ লট অফ পিপল। আমি দেখেছি যে তারা কখনো কোনো কথাবার্তা বলে না, এমনকি আমার কোর্সে আছে এটাও আমি জানি না, কিন্তু রেজাল্টের পরে দেখি সবাই পাস করে, এন্ড আই জাস্ট লাভ ইট, ইউ নো, আই জাস্ট লাভ ইট। Like a lot of people, there are a lot of people who doesn't say anything during classes, doesn't say anything during classes. I don't even know that they are in my course, but after the result I see all of them passes. There are some people who likes to stay silent, just like me, like all day I don't talk at all. I just don't talk at all. What do? I get up from sleep, I do some work, I go to work, I go to gym. I don't talk. I don't talk at all. I don't talk to anyone except with my boy. I talk a little bit, but not that much. Not that. I just don't talk. Like collectively in 24 hours, I say 24 words. One word, 1 hour. One word an hour. But whenever I take a class, I talk a lot because I love taking classes for MRCS Part A. I just love it. So then what do you have to do in case of raised ICP? You need to know Cushing triad, and you need to know what can you do non-surgically to decrease the ICP. Now you can raise the head end, let's say 30 to 45 degree, 30 degree, 30 degree. That will very simple and easy. Gravity will pull some blood from head, and ICP can be lowered a little bit. Mild hyperventilation will cause CO2 washout. And again, and mannitol. Okay, mannitol is an osmotic diuretic. It will reduce some water from your body. To make it simple, reduce some water from your body, so blood volume will be a little bit less. Okay, then of course dexamethasone and CSF drain, we can do it. Just remember these four, these two from above, they most of the time they give these two. Okay, then what can increase your ICP? We all know traumatic brain injury, most commonly EDH, most commonly decompressive craniotomy. We do decompressive craniotomy or bar hole, this operation. Okay, so you can use hyperventilation as temporary measure, but do not hyperventilate for first 24 hours. Do not hyperventilate for prolonged period. Do not hyperventilate without brain oxygen monitoring. Should not stop suddenly. Risk of rebound, increased ICP. Okay, as prophylaxis. So do not do it in these cases. Remember these cases. If pupil is dilated unilaterally, craniotomy at the same sided pupil side. This will come as emergency question, not from head neck surgery. Then Lefort fracture, most of the time they give Lefort type 3. If you don't understand, which kind of Lefort it is, select type 3. If you don't understand which kind, if you understand which kind, that's great. That can be 2, that can be 3. But if you don't understand which kind of Lefort it is, select 3. Because around the year, like from last 10 years, though question patterns have changed from last 2-3 years, still the Lefort question they gave, I never found a question with Lefort 2. But it doesn't mean that Lefort 2 cannot come. It can come, but almost in 90% cases they gave Lefort 3 fracture. So if you don't understand, if it feels complex to you, only in that case select Lefort 3. Paranasal sinus, you can have a question from paranasal sinus and posterior ethmoid sinus only, mostly posterior ethmoid sinus, but other you can have. But these are just 2 lines you studied, 100% important. Very, very important. Orbital floor fracture, just remember that teardrop sign. Teardrop sign in skull X-ray is maxillary, it's orbital floor fracture. And most of the time, maxilla is fractured. Maxilla is fractured. Just remember these two informations. Others not so important. Forget it. This one. This one. Here we have teardrop, air fluid level. Just give a reading. Just give a reading. Treatment. Just give a reading. These not important. And remember one thing, that if they tell you that there is a periorbital orbital hematoma, but no, anytime they say no sign of fracture in X-ray, what do? You do MRI. Anytime they say no sign of fracture, remember to do MRI for soft tissue visualization, soft tissue injury. So you do an MRI. Then skin and others. Skin and others, others from just this line, 100% important. This line, they give sometimes from autoclave, ethylene oxide, glutaraldehyde. Just remember these two. Normal endoscope, normal endoscope, glutaraldehyde. Normal arthroscope, any scope, normal glutaraldehyde. But flexible, if they say flexible, ethylene oxide. Just these two. Autoclave, remember this line. Remember this line. These not important, forget it. Autoclave, remember this line. And it does not eliminate Clostridium spore. We have it in our arrows. If it's done below 121 degree. If the temperature you did autoclave but in 100 degrees. So Clostridium spore will be there. Just remember it. Just remember which one's thicker. Just remember which one's thicker. One is thicker than 10. One is thicker than 0. 0 is thicker than 20, 30, like this. Just remember this. Diathermy. Just remember that a person after OT has burned under umbilicus. Umbilicus. What is the reason? The foot plate is not placed correctly. Just remember this statement. Okay. Others not important. They don't ask. And another thing, in tonsillitis, we use bipolar. In thyroid surgeries, we use bipolar is better. Bipolar, because there are surrounding structures, surrounding a lot of structure that can be damaged by monopolar. So bipolar is choice for tonsillitis or thyroid surgeries. Graft and flap, 100% important. Allograft, synthetic, xenograft, auto, allo, xeno, all these things. Synthetic graft or isograft. Then about STSD and flap, just this one. Just this one. Just remember what do I say. Just remember what I say during classes, that if they do not mention anything about periosteum, periosteum is intact. So go for STSG. If they specifically mention that periosteum is gone, no periosteum, do flap. Okay, do flap. Just remember this point. No matter how big the stem is, you will find these points from your stem. Then graft rejection. Graft rejection, what do we use? They don't ask. They don't ask. Just they tell you that this one, this chart, hyperacute, acute, and chronic, and graft versus host disease. The day. Okay. Immediately at the time of surgery, 7 day, they will mention day. if they mention day, sometimes they 10 or 15. They mention day. That's acute rejection. Then they mention over months, 1 month, 3 month. That's chronic rejection. Okay, that's chronic rejection. You have to just see the time frame. They just ask what kind of rejection is it. It is. Then renal artery thrombosis, renal vein thrombosis, blocked catheter. You must know these things. Must know these things. And these two, EBV, CMV. Before 6 months, CMV. Beyond 6 months or after 6 months, Epstein-Barr virus. Skin lesion, these are not important. Forget it. Just remember BCC. BCC, raised, remember the clues. Raised everted edge, central ulcer, okay, just remember these things. Central ulcer or basaloid features. Remember these words. Basaloid feature, or they say telangiectasia at the base. Telangiectasia at the base, all these things. These are BCC. They will just give diagnosis. And malignant melanoma, they will always mention color change. Color change. Others, no, they don't give some, they don't give much, but squamous cell carcinoma, this is important. Okay, then just diagnosis. Remember Breslow thickness. Remember Breslow thickness. This is for malignant melanoma. And remember, success depends on completeness of excision. Okay, this is the most common type is nodular. Remember, most common type is nodular. Only these lines. Only these lines. Others, they don't give. Just remember this success depends on completeness of excision. Just remember this line. Just remember this line. They will not ask you how much margin you have to take. Just remember that any number they give, remember 0.5 centimeter. Add 0.5 centimeter to it. And if they give like this, the 1 to 2 millimeter, okay, 1 to 2 millimeter, 2 to 4 millimeter, you know, if you have studied previously, you give a revise. Otherwise, not needed right now. But this line is 100% important. Risk assessment, not important. Not important. Not important. If you have studied previously, enough. Kaposi sarcoma, important. 100% for your upcoming exam. Remember the cause. Human herpes virus 8. Other skin conditions. Dermatitis herpetiformis, pyoderma gangrenosum. Keloid scar, hypertrophic scar, Marjolin scar, acanthosis, all of it. Single questions they can give sometimes. All of it are important. And keloid scar and acanthosis nigricans. This is acanthosis nigricans. They will tell you that purple lesion. Purple lesion. Okay. So these are the things you need to study from here. But remember, you study it just once or twice, or today. Only today you study it, or tomorrow, only 24 hours. After that, you study emergency trauma perioperative. Anytime you get, you study emergency trauma perioperative. When I start anatomy, study nothing but anatomy. So you don't have time for emergency trauma afterwards. So study emergency trauma perioperative rest of the days. Thank you guys. Best of luck. Good night.